Hello, my name is Dorah Labatte, and I'm a DRPH candidate at the Colorado School of Public Health at the University of Colorado. And I will be presenting my work examining prenatal acetaminophen use and birth outcomes. So acetaminophen, commonly known as Tylenol, is widely used during pregnancy and generally considered safe. However, given its ability to cross the placenta, it is important to better understand whether prenatal exposure may influence outcomes like preterm birth or fetal growth. So first, I'll provide some background on why this question is important. Over 65% of pregnant individuals in the United States report using acetaminophen at some point during pregnancy. The FDA considers acetaminophen safe for use during pregnancy, which contributes to its widespread use. However, acetaminophen does cross the placental barrier, meaning the fetus is directly exposed. Prior studies have suggested potential associations with preterm birth and intrauterine growth restriction, including small for gestational age, also known as SGA, which you'll see me refer to it as in my slides that are coming. So despite this, findings have been inconsistent and confounding by indication, just like any other drug study is a concern. So meaning the underlying reason for use, such as fever and pain, which is why people use acetaminophen, remains a concern. So to address this question, we conducted a secondary analysis within a well-established birth cohort. This was a secondary analysis of the Project Viva longitudinal birth cohort based in Boston, Massachusetts. Within the cohort, we examined acetaminophen use, which was self-reported separately in the first and second trimesters, and we evaluated associations with two primary outcomes, including preterm birth and birth size, which was categorized as small for gestational age, large for gestational age, and appropriate for gestational age, which was the reference group. We also examined frequency of use to assess potential dose response patterns given some previous studies. And finally, we conducted a negative control analysis using ibuprofen to assess potential confounding by indication, considering previous studies have always noted this as a limitation. Now I'll walk through what we found. So 49% of mothers reported acetaminophen use in the first trimester. Overall, acetaminophen use was common in our cohort, which is reflective of the national average, the national prevalence. And then in the second trimester, about 63% reported use. And mothers who reported using acetaminophen 10 times or more, so those who reported a high frequency of use, that was considered a high frequency category, had 71% higher odds of preterm delivery compared to never users. We also observed similar associations as it related to preterm birth when examining ibuprofen use, and these patterns suggest that with preterm birth, there may reflect some confounding by indication, again, which means that the underlying ailments, so pain and fever, requiring the medication may be driving the risk. Interestingly, more frequent acetaminophen use was also associated with lower odds of small for gestational age, which we did not see with ibuprofen. So there may be some interaction there. So in general, how do we interpret these findings? Well, overall, conditions that prompt acetaminophen use, such as fever, infection, or pain, are themselves established risk factors for preterm birth. So there is evidence in this case of confounding by indication as it relates to preterm birth, especially given that some of the findings with ibuprofen strengthen the possibility of confounding by indication. The inverse association with SGA, so small for gestational age, is a little bit more difficult to interpret. It is possible that acetaminophen's antipyretic or physiologic effects may influence fetal growth pathways, but this requires some further investigation and may be causal. But overall, these findings highlight the importance of carefully considering underlying maternal conditions when evaluating medication safety during pregnancy. Finally, I'll briefly discuss what's next. Well, what's next? Well, future research should aim to replicate these findings in larger, more diverse populations. Studies should incorporate more detailed information on indication, dose, and duration of use, which is a conclusion of some previous studies as well. And ultimately, the goal is not to discourage appropriate treatment, but to better but to provide better evidence to guide counseling for pregnant patients who require pain or fever management. Given how common acetaminophen use is during pregnancy, even small effects could have important public health implications. Thank you so much.